Good evening, everybody. Welcome to RDAA's second Destination Rural webinar. Our title tonight is Rural GP or Rural Generalist, same but different. Before I introduce to you our esteemed panel, I'd like to acknowledge the traditional owners of the lands on which we meet tonight, be they spread across this great nation, and pay our respects to the elders past, present and emerging. Our panel tonight, I will introduce now. So we've got Dr. Melanie Considine from Clare in South Australia. We've got Dr. Ewan McPhee, the former RDAA president and current ACRM president. And he's here in his role tonight as a rural generalist working in Emerald, Queensland. We've got Dr. Ben Dodds, who's a rural generalist registrar from Tasmania, and Dr. Laura Harris, who's a rural registrar from Bright in Victoria. I'll give you a bit of background about myself before we kick off into the juicy content tonight. My name's John Hall, and I'm a rural generalist with advanced skills in obstetrics. I predominantly work in general practice, Toowoomba and Oakey in southwestern Queensland. So most day-to-day is office-based general practice with some hospital and locum work. So I maintain my rural generalist GP obstetric skills by doing remote locums because we don't have obstetrics in the towns where I work. And as you'll find out, and as may come up in the discussion, it's not always easy for rural generalists to actually get roles in regional hospitals, and that's a bone of contention, but something that we can talk to tonight. To help with the structure of tonight's discussion, we're going to be using the Collinggrove Agreement definition of a rural generalist as a way to define whether a doctor is working in rural generalist practice or as a rural GP without that title of rural generalist. I'm going to read out the Collinggrove definition now just so that we're all aware. And for those that don't have the background of the history, this was a landmark agreement between the colleges essentially coming up with a consensus around what we all mean when we use the term rural generalist, which is really important for our own understanding, but also for workforce planning and health economics going forward. So I'll read it out. A rural generalist is a medical practitioner who is trained to meet the specific current and future healthcare needs of Australian rural and remote communities in a sustainable, cost-effective way by providing both comprehensive general practice and emergency care and required components of other medical specialist care in hospital and or community settings as part of a rural healthcare team. So it's a bit of a mouthful, but it does have, important components, and you need to meet all of those requirements to fit the definition of the we know today. Now I'm going to move on and introduce to you and get the panel members to introduce themselves in more detail to you, to give you a bit of background as to them personally and also about where they work and the model of care that they work in. We've carefully constructed the panel today to give you a broad cross-section of different models of care and different types of practice. So to kick it off for us, I'll go to Mel Considine in South Australia and get her to give you a bit of background on where she's from.
Thanks, John. Hi, everyone, and welcome to this webinar. I think it's going to be an interesting discussion tonight. And I'm sorry my video is not working. I don't know if there's an image of me, but it doesn't really matter. You're not missing out on much. So I'm a rural GP or a rural generalist, depending on who you talk to, because I do think perhaps that I would meet the definition in the Collinggrove Agreement if we looked into it. So I fellowed with the RACGP in 2014 and began work as a GP on the Eyre Peninsula in South Australia, living in a town called Cleve, and also working in Elliston and Kimber, which are all relatively isolated as far as South Australia goes. So that was an interesting experience and a really good one. And it gave my husband, Jerry, and I a really good exposure to, I guess, generalist practice, really. managing emergency cases, on call 1 in 3, a remote site, clinic, general practice during the day. And I'm now working in Clare, so quite a different location, in a bigger group practice with about 14 GPs. I work part-time because I have 2 little children at the moment, and I have special interests including lactation and breastfeeding, as well as doing shared obstetric care. So I've completed my International Board of Lactation Consultant Examiners certificate this year. So that's been a really interesting part of my practice, and also share the on-call roster with my colleagues here, so do a lot of emergency work and inpatient work as well. I don't, however, have a procedural skill like anaesthetic or obstetrics or surgery. So that's me in a nutshell.
Thanks, Mel. And look, based on your description, I think you definitely meet the Colin Grove agreement definition of that you do and those advanced skills. Moving on to Ben in Tassie, our RG registrar. Do you want to kick off, Ben, with your story?
Thanks, John. So, hi, everyone. Ben, living in northwest Tasmania. Only a very new graduate, first-year ACRM trainee, based in the hospital at the moment, working through the core clinical requirements, such as paediatrics, obstetrics, and the anaesthetics requirement. I've been involved in rural health for a few years now, mainly as a medical student with the National Rural Health Student Network, and now with the Rural Doctors Association of Tasmania and Australia. And I've been really lucky to work in lots of different rural settings. We've got 2 main regional hospitals here on the northwest and a couple of smaller rural inpatient facilities as well, and had a great time last year working in Queenstown on the west coast for 3 months, which involved general practice, inpatient care and emergency medicine. So I hope that tonight I can share some of the stories about why I'm enjoying working in rural practice and how I'm hopefully going to shape a career with it using the ACRM model.
That's fantastic, Ben. Thanks for giving us those insights. Now we'll move on to Laura, and she's coming to us from Bright in Victoria. So Laura, we're ready for your story.
Hello, everyone. So I'm Laura. I'm a RAC GP, GPT2, AGPT, is that enough letters, registrar who is, I've just started, I'm 6 months into clinic-based GP training. I'm really enjoying it so far. My day-to-day kind of involves working at a small clinic in Bright. We're the only clinic in town, and we also kind of staff the clinic up at Mount Hotham as well. We do the on-call for our local kind of 9-bed small urgent care centre as well. So far, it seems to be a really good mix of exactly kind of, the right balance of acute medicine as well as kind of responding to community needs, which I think was really mentioned in the definition of being a rural generalist. And I'm really enjoying it so far.
That's fantastic. Thank you, Laura. Cool. Okay. Well, I'm going to give you a bit more about me as well. Interestingly, I want to make it really clear from the get-go that when we talk about rural generalists, we're not saying that a rural generalist is better or that it's a better model of care. They're just different, and that's hopefully brought out in the title of tonight. There's certainly a really important role for office-based general practice in rural areas, but equally hospital-based care is essential and important as well. So the different models are both important and both really necessary, and really whether you choose to work in more hospital work or more office-based practice or in some form of combination of the two doesn't make you better or worse. It just makes your practice a little bit different. And for me individually, I work in a town called Oakey quite a bit as part of my day job. I did 10 years as the med super there, running a small emergency department and inpatient care, but now I stopped doing that about 2 years ago. So in my day-to-day work now, I would class myself as an office-based GP in that model. So there's some days where I'm working as a GP and then I do my locum procedural obstetrics intermittently. And so essentially on the days that I'm home working in my practice and not doing hospital work, I'm a GP. And at the times when I'm doing my hospital work as a locum, I'm a rural generalist. So I think one of the beauties of rural practice for me is the ability to move between models of care, and that we can gain the benefits from the ability to move between models from time to time. I'm going to now move on and go to our first sort of question. So in many rural communities, we see a combination of rural generalists and rural GPs working alongside each other, and it's certainly true for Oakey, where I live. I'm going to go to Ewan and just ask the question, what do you see as the main differences between the type of work each role does, as I've described?
Thanks very much, John. Just to introduce myself, I've been a 30-year veteran of Emerald, which is in central Queensland. I consider myself a rural generalist, and I guess if I could talk about a day in my life, and say yesterday I started with an induction in the morning, a lady who needed to have a baby, coming down to the practice then and with a medical student doing a morning of chronic disease, complex patients in general practice, did a knee aspiration, popped back up and delivered a baby, came back down, did some mine medical work because I'm an authorised medical assessor for a number of coal mines in my region, and also did some aviation medicine work as well. So I guess in that day I was able to have a continuum between chronic, complex, multimorbidity patients that we know are very common in rural general practice, through acute procedural medicine and emergency medicine through delivery and resuscitation of a baby and management of a postpartum hemorrhage, through to other aspects or opportunities in rural practice particularly, which relate to occupational medicine and health and safety. So it's a broad continuum. And look, I work in a practice now. I've sold my practice to a community not for loss, and I have a number of other clinicians with me, and there are about 9 in my practice. The other doctors do an excellent job. They work within the practice, both doing usual office-based general practice, but also their own specific interests, which include skin cancer medicine or women's health, or mental health and psychology services. So we have a number of rural generalists who have some extended scope of practice, and some rural GPs who are really doing very much the important work that any GP would do across the country. And it's just about being a generalist, and it's about where your scope fits. And a rural generalist generally has a scope that extends from primary care to secondary care across that continuum at some point. And it's a little bit different from that of a GP working predominantly in general practice. But that's not to say that either is better or worse. It's just what I found very important is that we really need to describe rural practice and capture it in its entirety, because one of the key issues for us is future recruitment, future retention, recognition, remuneration, all those important things that a national rural generalist pathway will bring forward. John, I hope that gives you some ideas about what I think the differences are.
No, that's great. And again, backs up, what we discussed around the agreement and some of the things that have already been said. Moving on now to Melanie, can you give us your ideas as to what you think the main differences between, say, a GP and a rural generalist?
Thanks, John. Look, I think essentially I'd be echoing what Ewan has just said, that it's looking more so, I guess, at the scope of practice, and that it extends beyond office-based general practice into secondary care, so in a hospital setting or in an emergency setting, potentially also with other special skills, and whether that's procedural or not, it doesn't necessarily have to be, I guess, your classic skills like anaesthetics and obstetrics. It can be things like mental health or palliative care, for instance. So, yeah, look, similar lines really, and again, echoing that it's really not about anything better than, it's just different. And with that title of Rural Generalist, I guess one of the reasons behind it is a bit of a political motivation as well, to try and, I guess, enhance the role of rural practitioners and highlight the wonderful work that we do as rural clinicians, and to hopefully then encourage other people, medical students, junior doctors, to actually come and do this wonderful work.
Absolutely. No, that's really good, Mel, and I completely agree with you. I think along those lines of the political aspirations with rural generalism is that we see that people that are working across primary and secondary care often have to work in insociable hours and are doing the on-call and some of the more challenging, or socially challenging shifts. And we firmly believe that these people should be rewarded for that work. And part of our drive to get rural generalism recognised is to, in part, look at better remuneration and awards for people working in this type of practice. So that's great. Moving on to our next question, we're going to ask the panel, what type of professional development do we need to maintain with our skills as rural generalists, and that compared with working as a GP? So I might touch on that myself first before I go to some of the other panel members. But one of the challenges of being a rural generalist, particularly if you have more than one advanced skill, or if you have skills across a range of a GP subspecialties, like for myself, for instance, I do complex skin cancer medicine. I've got a diploma in skin cancer as well as obstetrics. So I've got to maintain CPD in the skin cancer space, and also things like ultrasound, emergency care, and obstetrics. So that can be challenging in and of itself. I find that I do my CPD through ACRM, and I think they've got a really well organised process for that suits me and it suits my practice. But often it involves upskilling, so going to larger centres, particularly for my obstetrics, so spending 2 to 3 weeks a year in a larger centre, getting exposure to procedural work. And then there's a lot of course-based upskilling that I do for things like ultrasound, for emergency obstetrics, for paediatrics and emergency trauma. So there are some really good structured courses that you can do on a triennial basis, like EMST and APLS, and also many of these courses are now becoming required for your credentialing in hospital practice as well. So it is a challenge, but it's also interesting, and I think it makes me feel more confident and competent having that upskilling and the CPD up to date, because things do change, and it is quite a challenge in generalist practice, staying across all of the updates and changing guidelines and fast moving evidence. It is quite a challenge to stay up to date with everything, and you do need contact with people that are driving the education, and also metro centres where a lot of this stuff is being driven to maintain your skills across a broad range of disciplines. So that's my experience with CPD. I might throw to you, Ewan, to give us your understanding of CPD and how you keep up to date.
Thanks very much. And I think just recognising Marion's question as well, that being a generalist, you have so many interests, and how do you keep your head above water with CPD? I think I got 2 comments. One is you do need to, I guess, make sure you're across your scope if you're going to have a scope of practice, and where you can, work with other clinicians who complement you in your practice. So where you have an opportunity to work in a community where someone has an interest in anaesthetics. It'd be great if you're an obstetrician, or if you've got clinicians who really enjoy mental health and dealing with mental health issues, working with those in your practice in the community. So when I first became a doctor, I did anaesthetics, obstetrics, surgery, general practice, and everything. I also worked 20 hours a day and 7 days a week, and simply people don't want to work like that anymore. So CPD is important. Look, I restricted my practice to obstetrics and general practice for that reason. I also would like to say that it's really important that the general practice colleges make sure that we are doing the CPD for our scope of practice, and that includes our generalist scope of practice. There's a real challenge for us at the moment, and that's about other specialist disciplines offering or taking control of the scope of practice, which is a general scope of practice, and then us having to go out and buy or seek or pursue CME from other colleges. Part of this Rural Generalist program will be really to focus on saying, look, emergency medicine is part of scope of Rural Generalist. Obstetrics is part of scope, and really starting to challenge the multiple diplomatosis that we're really going to fall into if we're not careful. So for Rural Generalists and for Rural GPs, we really need to own what we do. And so I guess to answer the question succinctly, I use ACRM for my CME because it offers me what I need. I am a dual fellow of both colleges. But also, I think that both colleges, through the National Rural Generalist pathway, will be pursuing rural generalists and rural GPs owning their scope of practice. Thanks, John.
No, that's great, Ewan. I think that was really well put. I'm a dual fellow as well, and whilst I process my CPD through ACRM, I also do use RSCGP's resources and GP learning, and there's lots of good stuff across the board there, particularly with the online content. So moving on to Mel, and particularly around staying up to date in the general practice space. Can you give us your insights into that, Melanie?
Thank you. Yes, look, I guess it's similar to both yourself and Ewan, really. I mean, we all have CPD requirements that we have to meet, and I do mine through RACGP mainly because I'm a fellow of that college. And I guess we each do tailor our CPD to our special areas of interest anyway, but I agree absolutely, wholeheartedly with what Ewan was saying, that our colleges have to own these things, and you know, a lot of these areas, like even, you know, skin cancer, emergency medicine, palliative care, they are within the scope of practice of a GP working in a rural setting particularly. So really important that that's done well in this new training program that's, you know, being looked at. So yes, I do my CPD at the moment through RACGP, and the extra training that I've done, particularly the lactation consultant training, I do have to do CPD separately through that international board, because it is just a separate qualification, and it's just how that works. So I'm going to have to just keep an eye on that as a separate thing. So it's sort of that keeping all your balls up in the air and making sure you meet those requirements at different time frames. Look, it is challenging, and Marian's right in her question that, you know, all of we do seem to want to do it all as rural generalists or rural GPs, and we've got lots of different interests, and that's one of the attracting features of working rurally, is you can do lots of different things. The work is quite varied and interesting, but I guess in a way your patients help you to hone in on your special areas of interest, because you start to find out what you're really good at. Patients see you for those things, word of mouth spreads, and you see more of that and you get better at those things. So I guess in time you kind of do hone in maybe 2 or 3 particular special areas of interest that you do really well. And then, yeah, if you're with colleagues that complement your skills, that's ideal.
Absolutely. Couldn't agree more. And I think both yourself and Ewan have summed that up nicely around our CPD and ongoing care. I'll go to Marion's question as well, and I think it's very doable to stay current across those disciplines. Obviously, in the past, there were many people that did multiple advanced skills, and that's less common these days. But the very nature of generalist practice means that we need to work across those range of disciplines. And I think utilising the resources that both Ewan and Mel have discussed, I think we can get across those areas. And I think another way of staying current is in models of care where we've got specialist colleagues who regularly visit or work alongside us. And I think that's another thing that needs to be encouraged to help keep us up to date in situ, rather than having to go other places to do that or be at the whim of other colleges or organisations, as Ewan said. But moving on, we're going to talk a bit more about training now and the differences between training for office-based GP and a rural generalist. One of the key differences is for ACRM and for RACGP doctors that train towards rural generalism, they require a 12-month study towards an advanced skill. I'm going to go to you, Laura. What were the key elements of training that attracted you to the pathway that you're currently on?
Yeah, thanks, John. Look, I think it kind of comes down to three main things for me. Was that I liked doing a bit of everything, so I thought that doing something in general practice was going to be a good idea to keep my interest with that. I really liked acute medicine, but the other thing that I found in the hospital setting was that I really liked continuity of care, and it really frustrated me in the hospital setting when we couldn't find out what happened to someone, or what was the result of those scans we'd ordered 6 months down the track when they just kind of go off into the ether. So I guess kind of to share a little bit about my path and how I kind of ended up, I guess, on this rural generalist kind of pathway was that so I'm from Melbourne. I started in doing my internship and most of my study through the Austin Hospital in Melbourne. But throughout my intern and my subsequent residency years, I kind of kept a broad kind of general focus, keeping in mind the skills that I thought I'd kind of need to cover as a rural GP. And the whole way through that, it was really important to me to kind of keep those links to going rural. So I worked up in Echuca, I worked up in Mildura, and I actually worked in Katherine in the Northern Territory, because I wanted to keep, as well as understanding how the city hospitals worked, kind of keep that link with what's happening in the rural setting, and building my confidence to kind of, make decisions when I wasn't surrounded by a big tertiary hospital. I guess in kind of, there's other elements in extra study that we've kind of that Ewan kind of touched on, that we can do along the way. So I found things like doing that ALS course helpful. I spent 6 months doing my diploma of O&G last year, because I really wanted to be kind of confident and competent at women's health before going into general practice. I think it is also really, really important to, surround yourself and, take opportunities to meet people who are on similar kind of generalist kind of journeys. Queensland's been doing this model really, really well for years. And so, like, prior to doing my obstetrics training, I did manage to do an introductory course with the generalist stream based in Queensland in Townsville. I found that really, really helpful. Also through things like the RMA conference, meeting people that are working as rural generalists can be really, really helpful in kind of giving you practical tips, and also inspiring you a bit about, their journeys and what might be your, to help you shape your own journey.
Well, that's great. That's it's a fascinating insight, and it's good to see you so keen and interested and getting along that path. So good on you. Ben, can you talk to us about the key elements of either rural GP or RG training that attracted you to the pathway you're on? You're muted. We can't hear you.
There we go. Fixed it. Thanks, John. So for me, general practice has been an idea of what medicine meant to me from when I started. And I think being exposed to that when I was at school, visiting the general practice, where where my mum worked as a nurse was sort of what I thought medicine was and where I've always headed. I've always enjoyed the type of medicine that was there. And then as I went through medical training and internship, I decided, look, there's no one thing that I can narrow it down to, and I enjoy all sorts of aspects, including the acute medicine as well. So the ACRM structure for me was what I have set forward onto, which I think is going to give me the solid foundation for a primary care career with advanced skills and acute medicine. And the main thing about it is the flexibility. So at the moment, it's the flexibility to train how I want to and in the place that I want to. I'm training in the town that I grew up in, and I'm working out which rotations I require, what I think I'm going to need to be a good practitioner, what are some of the things that I'm interested in. So, for example, working in the hospital, seeing palliative care medicine, seeing that there's a community need for good palliative care medicine, both community-based and hospital-based, and thinking that's actually something that I'm really interested in, and then be able to structure that within the framework of ACRM to build that into a career training is part of the bit that's attracted it. I think the core part, which we hear time and time again, is that actually training in the rural areas as well is really beneficial. So the hands-on experience, the close mentoring, and the ability to, stick your hand up and say, look, I want to have a go and I want to learn this, and having people help you with that has been really good. I think moving forward, what's good is that as life changes, as the community changes, I have that background as a primary care practitioner to be able to work with. And if I decide that I would like to do something else, I have that foundation to build on and work towards a new advanced skill. So I think overall that's what's attracted me to the RG pathway.
Oh, that's great. And look, I think you've hit on a really good point around doing your training in rural areas and a lot of regional hospitals as well, where you do get much more exposure to hands-on clinical practice, much more so than waiting in a queue of 10, registrars or students in a major tertiary centre. So I think it's a really important advantage of training in the bush is that clinical exposure and the quantity and the volume of exposure that you enjoy that often our metro cousins don't get. So moving on, for you, Ben, I guess there's the next question really. What support do you receive from your college, the RTOs, your mentors and supervisors towards your RG training? Can you touch on that for us?
Yeah, so actually just before our webinar tonight, I was having a remote training meeting with the other ACRM registrars within Tasmania. So there's only a very small group of us. RG training is something that's relatively new within Tassie. So we have a good group of 7 or 8 of us that is organised and supported through General Practice Training Tasmania, and we're actually talking about palliative care emergencies, and it was based on someone's experiences. So the support from GPTT to help each other with our learning and our preparation for exams and things like that is really important. And we have not only these remote meetups, but also in-person meetups, and not always just educational, but actually social from some perspectives and networking. So it's really great when we get other doctors that have worked in other parts of Australia and in some cases around the world that have come to our part to work for a couple of weeks, do a locum, meet up and hear their experiences, hear their training pathways, hear what you can do with the RG model, which is supported through our RTO. The other really good thing that RTO provides is a medical educator. So with flexibility is obviously a lot of choice, and that can sometimes create a bit of confusion, and you do have to seek out your opportunities, you do have to seek out your pathways, you have to figure out how you're going to fulfill the requirements for the fellowship, and how that's going to fit in with the workforce model and the hospital model that's available in your area. So they help you guide through that mentoring process as well. and meet your different requirements for fellowships such as exams.
Oh, that's great. Laura, can you tell us about the supports you get from your college and the RTOs and your supervisors? But before you do that, I'll just remind the participants that you can ask questions on the webcasting page. So feel free to type in any questions as we go along, and we'll endeavour to get to your questions as they come up.
Yeah, thanks, John. So I guess at a college level, like I find some of the RACGP resources. Similarly, I find the ACRM resources really handy as well. But some of the GP learnings, the check guides are a really, really helpful way to kind of do some kind of self-directed learning and keep up to date, particularly in kind of what's new and what's coming out. I think, the landscape of how we kind of get information as GPs is really changing. Like we see so much more, a lot of updates and that kind of things is now through college-based things, updated on Twitter, updated on Facebook. So that can actually be kind of a handy way to keep on top of new issues as well. I think in terms of my training organisation, I'm doing my training through MCCC. They've been really, really supportive in terms of we have workshops where it's good because you get to face-to-face network with who else is in your local area and learn, skills, communication skills together as well. In terms of, I'd say my day-to-day, it's really, really important to surround yourself with supervisors and mentors that you trust and respect and are willing to kind of go the extra mile to teach you different things along the way. And I feel pretty lucky to be surrounded by some really good supervisors that have really helped and guide me along the way.
That's fantastic, and it sounds like you're really well supported where you are, which is good to hear. So moving on, we know that some trainees think that if they train as a rural generalist, that they'll work mostly in a hospital practicing an advanced skill. I want to go to Melanie and Ewan and just get a bit of a reality check here and to find out from them whether that's actually the case and some insights around, what hospitalist practice looks like in the rural generalist space. So Melanie, can you touch on that for us?
Yes, thanks, John. Look, I guess if trainees are thinking if they train as a rural generalist, they'll work in the hospital all the time. I don't think that is the case. And if that is the case, I'd actually probably say that they're probably not working as a rural generalist because I don't think that encompasses generalism or the Colin Grove Agreement for that matter. So I guess it comes back to that mix, that scope of practice from primary to secondary care. And from my perspective, what I see in practice, and this is, of course, it differs from site to site, and depending on the size of your town or your region, your hospital, your clinic, how many doctors you share the on-call load with, that sort of thing. But the doctors that I see who have an advanced skill, for instance, obstetrics, do a lot of primary care clinic work in the general practice from day to day, and will also do their hospital work when they need to with a separate on-call obstetric roster, and same for those doing anaesthetics. We've got a couple of GPs in the clinic, and myself included, who do a little bit more of the mental health side of things, and of course my lactation side of things, as well as baby sleep, settling, those sorts of issues. So we've all got our special interests, and yeah, in my region at least, it's not the case where you end up just doing your advanced skill in the hospital all the time and not actually getting that broader scope of clinic work, which I think is where the interest lies, really. Most people who go into rural generalism are wanting to do a bit of everything because we can't really hone that down. That's why we want to do general practice. So that's my take on it.
No, that's great. Ewan, anything to add to that debate around hospital-only practice?
Thanks, John. I think Melanie does capture some of those issues. I guess there's two comments. I think recognising that Queensland has an excellent rural generalist program, and that we are seeing one of the priorities for the rural generalist program in Queensland was that the procedural disciplines were really struggling. And so there was a focus on, really building that procedural disciplines within hospitals. What we're now seeing is that we need to transition more to cognitive skills, and these are really community-based skills, and we're starting to see that transition from hospitalists to community-based clinicians, and that's an important acknowledgement that the generalist really needs to sit across both. And I think it's important to recognise that some people are functioning almost totally within the scope of their enhanced scope of practice, but they do have primary care qualifications. So they do need to understand at some point they are GPs, and that they should be mindful, I guess, of general practice, but also be able to transition to general practice at some point in their career should they choose to do so. So hospital practice can just be part of the continuum. It can be part of your life progress where you work in a hospital for a period of time and then you move into country general practice. But we are seeing this transition in Queensland particularly towards the cognitive-based, community-based skill set, which really takes you outside of hospitals. So it's a challenging area. I like to think of generalists as people who can spread themselves across all paths. If you see yourself totally within a hospital, within your extended scope of practice, then perhaps that's your strength. Perhaps maybe you're not a rural generalist from the Colin Grove point of view, but you may be an excellent GP obstetrician. But it's being able to extend yourself across that scope of practice into community practice that is so important, that makes you a true generalist.
No, that's great, Ewan. And I think, I mean, a lot of the doctors that work in hospitals in Queensland are employed as full-time SMOs. And and initially when this was brought on board as a workforce program, it was unashamedly developed to try and populate our rural maternity units, and to ensure that our rural theatres, anaesthetics and the like continued and maintained those hospitals. So there was a component of that. But what we are seeing, as you've mentioned, is more of a move back towards the community. And we're seeing many of these SMOs take fractional appointments. So they might be only 0.6 or 0.8 in their full-time, in their hospital engagement, and then do a day or two a week in general practice. So there are ways of mixing it up where you might be primarily employed in the hospital and still be able to do some general practice. But there's certainly a need for these doctors to be generalists, because I can't think of a context where you can only work just in your extended scope. Most rural hospitals require you to work in emergency and do inpatient care and medical outpatients, plus your obstetrics, if that's what your skill is. So there's always going to be a demand for generalism, but we see the true seat of generalism still primary care, and that's what we're trying to encourage for sustainability going forward. So moving on, a lot of our young doctors in training talk about rural practice. They hear the horror stories of the single doctor towns and being on call 24/7 for weeks on end. The question to the panel is, is this true? Is that sort of level of work still happening? And do we get breaks? And what does the work-life balance really look like for people at the coalface? So I'll start with you, Mel.
Thanks, John. Look, again, I think it depends where in Australia you work. There certainly are still solo GPs out there. However, I seem to be observing that it is reducing. I just don't think it is sustainable for most people to be on call 24 hours a day, 7 days a week. Those who are solo GPs, those that I'm aware of, do get locum support to take breaks from their work. And many of them have registrars who work with them quite closely, which is excellent training. And I guess that's a little bit, increases their team, so to speak, doubles it. There are ways around it, but most of the time we're working in teams and sharing the on-call load. The most on-call I've ever done was that year on the Eyre Peninsula, which was 1 in 3, but my household was 2 in 3 really, with my husband and I across those 3 towns on the Eyre Peninsula. And for me, that was not sustainable into the long term. So just recognising what what our limits are, I guess, and, you know, what we can actually tolerate. It's not even necessarily if you do get called out, it's just knowing that you might be called out sometimes has enough impact on, you know, your level of sleep and things like that. So it is an important issue to think about. And it really comes down to the location of practice and how many GPs or rural generalists you can share the load with, what I can see.
That's good. That's good, Mel. I know there are certainly sites in Queensland where there's single doctors, but certainly it's Queensland Health policy to move away from that, and they're trying to recruit so that that's not the case. Ewan, do you have any insights into the on-call burden?
Thanks, John. Look, I think I've been here for 30 years. I've certainly had the luxury of seeing my town grow from myself and 2 or 3 other clinicians to over 30 doctors now. So the on-call burden certainly not onerous like it was, except that I'm on call for my obstetrics patients 24/7, 365. Because we do have a split system in Queensland, being a private GP, unless I have a VMO appointment at the hospital, then I really extended hours of my clinic. I don't do any other work unless I want to. So for me, I do a lot of on-call for myself and my patients. Other GPs in a well-doctored town don't have to do that. But we do have a number of rural generalists at the hospital who do emergency medicine, obstetrics, anaesthetics, do a fantastic job. And then these guys, because we have a critical mass in our bigger town, they have pretty good time off. So 8 days on, 8 days off, those sorts of arrangements are not uncommon in bigger towns where you've got a critical mass of workforce. But the key thing here is having the adequate number of doctors to be able to make it really effective for you so you can have great work-life balance. So I think my local hospital has pretty well got a full complement of doctors. I think we've had 4 or 5 babies born to local doctors now in the last 4 years. I think people have that real good balance between interest in clinical work and the ability to take time off and get away. But I think the key to that is building a workforce where you work in teams, building a workforce where you complement each other. Don't being a hero, don't taking on more than you can bear. Don't become ACRM president as well as everything else. That's a bit crazy. If you design things right and think about where you want to go and who you want to be with, don't hunt by yourself, hunt in a team, hunt in packs. I think that's one of the real secrets for my town, is being the fact that instead of just one doctor coming to town, we had 2 or 3. And they went to medical school together, and they enjoyed each other's company. They were great friends before they got here. And that really changes the dynamic of what's happening. And I think it's something for healthcare planners to think about, that you just don't want to train a vanilla GP or a vanilla rural generalist. You want to actually design something that's going to be meaningful, that someone will want to go and live and do for a period of time. Maybe not forever like me, but, for a few years at least. I hope that gives you some idea, John.
That's fantastic, Ewan, and I really like your comment, hunt in packs. I think that's so important. And one of my adages that I've health administrators before is that doctors recruit doctors. So you can take ownership of building the team around you, and often it's that attraction of a critical mass or a group of friends or a group of colleagues that get on well that can be your core that helps to recruit people with you and to your hospital and your model of care. Before we go on, I want to go to Marion's question, and she's put on the discussion board there that she's experienced some subspecialists have a fear and mistrust of rural generalists. And is asking if we can foresee a model where GPs, rural generalists and non-GP specialists work together. I'm happy to go to that, Marion, directly, because I've got some passionate insights into this myself. And I've worked in a model where this currently exists. But before we go to that model, I want to say to you, look, I think this is one of the realities of rural generalist practice, of being a rural GP, and it's been, existing for as long as I can remember. And I've spoken to older rural GP colleagues who've experienced this as well. But I think we have to go, we have to have thick skin. Working in rural Australia, I think there will always be suspicious or less supportive regional and metro specialists. In my experience, it's often the ones without any rural experience or the more inexperienced registrars and doctors in training that can treat us with suspicion or contempt. Doctors that have worked in the bush, that have cut their teeth, that have gone on to do specialty training often treat you with, high regard and respect because they know what you've been through and they've walked your path. So I think it's important to steel yourself and be prepared for that, but just to know and have confidence in your own ability and know that we are specialists. We're trained to do what we do across a general scope, and there's international evidence that supports the safety and efficacy of generalist practice that cuts beyond any opinion, that cuts beyond any question around safety. And sometimes the questions and the innuendo and the criticisms that come from super specialists are around whether we can do this safely because we're not doing 100 a day or that type of thing. But rest assured that there is clear evidence that we can practice safely and effectively. And in fact, when you go to maternity data, you look at the perinatal mortality rates and all of the indicators around induction rates, Caesar rates, and many of the key indicators that are measured across the world. Rural generalists perform exceedingly well and often better. So we've got strong evidence to support what we do. We're trained specialists. We have colleges to support us. So I think we need to be confident in what we do, have each other's backs, but be ready for it and be prepared to have the thick skin and to, in some ways, ignore the ignorance. But going to, is it possible to have a model like that? Absolutely. And I think it's something that we need to encourage. I've worked in Broome in Western Australia where they've got rural generalist teams. They've got GPs that work in the hospital who are primarily office-based GPs that do some of the teaching and some of the other work in the hospital. You've got doctors with emergency skills and anaesthetic skills that do some work in the Aboriginal Medical Service. And then you've got specialists. So they've got paediatricians and specialist obstetricians and gynecologists that work on the same rosters as the GP obstetricians and proceduralists. So they work in a very collegiate way, sharing rosters and responsibilities. But I've found it a very rewarding model of care in that you've got that extra backup and support of specialist practice around you. So you've got essentially upskilling in situ. So I think it's a great model. I think it's certainly something that we can aspire to. The big challenge is going to be encouraging specialists to come west of the Great Divide. It's one of the comments that I put to specialists that challenge rural generalist practice is, if you don't want us doing orthopedics or obstetrics, come and work where I work and do the work that the community requires. So look, just hopefully that answers your question, Marion, and we'll move on. We'll move on to our next topic. So I'm going to go to you, Ewan, again, and ask you what you find is the most challenging aspect of your practice.
Thanks, John. Look, I think it's just trying not to do everything. I love doing many different things, and I think sometimes I have to take stock of the fact that I can't do everything, and that sometimes I have to share the load or share it with other people. And I think that's because there's so many opportunities and so many wonderful things that you can do in rural practice, and I have such a diverse range of things that I have an opportunity to be involved with, and I think it's really exciting. But sometimes you've got to say, well, hey, maybe there's somebody better than me that can do that. So I think, John, I don't see rural general practice or rural generalism as challenging. I certainly see it as exciting and interesting, and I have the life that I wanted, and I've been here for 30 years, and probably will be here for 30 more. But, you know, I think this is I don't like talking about challenges so much as opportunities, and how you grasp those opportunities in a way that gives you a bit of work-life balance, gives you a meaningful career, but also is respectful for family and the other people you work with. So how's that for dodging the question?
Oh, well, I think it is a personality trait of many of us rural generalists that we, you know, it's a bit like Boyle's law, where we're like a gas and we expand to the container that you put us in. So I think it is something to be wary of and mindful of, so that we maintain that balance. I might cut to you now, Laura, if you can talk to us a bit about what you find challenging about your practice.
So I think there were probably two main things that really were big challenges when I started in small town GP land this year. One of the things was that, you know, Bright's a pretty small town. It's got about an average population of about 2,500. It goes up a lot more in summer. But one thing that took a little while of getting used to was that when you meet people in your rooms, they're the same people that were serving you down the street, that you'd run into in the street, that you'd be doing a gym class with. So I think just getting comfortable with that was, you know, something that was tricky to start with, but now doesn't seem to be a problem at all. I think the other big thing is that we need to kind of, in working in rural settings, is that we're, you know, continually checking in that, you know, our patients are getting the best possible care, and, you know, comparing and contrasting that to what they'd be experiencing in the city. And so sometimes I think from time to time, for things such as cancer treatment, people diagnosed with kind of quite rare conditions that I knew would be under subspecialist kind of management in the city. I think, you know, personally calling up and advocating for your patients in those situations can go a long way, and is an important thing to do when we're working a little bit more rurally.
No, that's really interesting. Ben, can you give us your insights into some of the challenges you've come across?
Thanks, John. I agree with both points that Laura made as well. Working in Queenstown on the West Coast, population was about the same size as Laura's town, about 2,500, and it is literally having difficult conversations with patients in rooms, and then they serve you in the supermarket, or you do a pap smear and then you see them in the servo. And it's acknowledging that that's difficult for you and difficult for them, and it's a part of rural general practice that you do learn to live with. A few of the practical things for me from a rural junior doctor perspective is that there is a workforce shortage in rural areas. So if you're trying to work and train, you may not always be in the best supportive environment if they can't find enough staff to work with you, and there's roster shortages and locums falling through and things like that. So you are sometimes expected to pick up extra work and do extra shifts because there is a patient safety issue where there might be no doctor on in the hospital overnight unless you're available to work there. So I think that is sometimes the bit that wears you down. And bringing on to Ewan's point, occasionally you do have to say no. You do have to look after yourself. In rural hospitals, sometimes there's pressure from the big tertiary specialty registrars that, no, you'll be fine, you can look after this patient. But advocating to say, actually, look, they'd be better off in a tertiary centre, and then once your subspecialty thinking is over, we can take over from there, and we're always happy to have our patients back. And I always do sort of put the same hat on as Laura and say, if they were in the city, what sort of care would they be getting? And I explained to my patient, look, I don't have access to XYZ. If I was in Hobart, this is what I'd do. This might be the differences in outcome. And I say to the patient, look, I'm happy to advocate on your behalf that you need to be flown out of here in the middle of the night to get the care that I think you need, and work with them to make a shared decision there. So I think there's some of the challenges and unique experiences that you can face in rural areas.
Oh, that's great, Ben. And I really take your point. our responsibility in rural towns. I think that can't be understated. I think it's really important for us to take personal responsibility for the service delivery in the town, and that, if something happens and our colleagues can't make it, then the buck does stop with whoever's in charge of the hospital or whoever's got charge of clinical governance there. And there's an important principle of ensuring that our hospitals are covered, albeit making sure that we look after ourselves. But I think there is that onus on us to ensure that our hospitals have coverage. And sometimes that might mean advocating for the provision of locum services. It doesn't mean you do everything. But I think we do need to take responsibility for ensuring that the emergency service is covered. Moving on now, I'm going to go to Mel, and I'm going to get you to, Mel, touch on if you've got anything that you think's a major challenge you want to bring up. But then going into our next point, which is I'm wanting to finish with the panel telling us the things that they find most rewarding. So the things that really keep them going, and things that really make their life as a rural doctor exciting and productive, and keep them in the towns where they're working. So, Mel, if you could move on to that for us, that'd be great.
No worries, John. Thank you. Look, everything that's been said already, and also with you and, focusing on the opportunities. But I guess sometimes I tend to be a little bit of a negative Nelly and think about the challenges as well. And look, I think being a GP or a generalist can experience, and in a good way. A couple of things I find particularly challenging at times, and one that I've experienced very recently is breaking bad news, particularly to that you see out and about, and it's really tough. And I think that can be the case for any clinician that has known a particular patient for a long period of time. Those conversations are always hard, and especially if you feel as though there's something more that there's always those could haves or should haves that you think about after the fact. So that is something that, at times can be quite a challenge. And the second thing I thought of was, my husband often says that I'm a bit of a confidence player. And I guess the more that you learn, the more you realise you don't know certain things. I guess it's part of that, but in the opposite vein. So, I do tend to get a little bit of that imposter syndrome, and especially in relation to intermediate exposure emergency scenarios with often limited resources, and just trying to make sure, obviously, that my skills are up to date if and when I come across those scenarios. So, so for me, I guess they're my major challenges but moving into the rewarding things about rural practice, and I do actually think both of those things that I've just mentioned as challenges are also really rewarding and fulfilling things, and drive you to be better. So I guess leading from that, the variety of work that we have in rural practice is amazing, potentially unlimited, which can be seen as a challenge or a problem by some people. But I think for most of us who are interested in rural practice, we actually find that a really rewarding, wonderful part of our work, that there's just so much variety. The flexibility of the work, I think, is actually a good thing in most towns, or the ones that I know well in South Australia, and certainly the one I'm in at the moment in Clare, with there being quite a few GPs now, we've got quite a good load to share. We just share the on-call roster. We're not on-call 24/7. It's flexible. If I've got to leave work for a sick child, which I had to do today, we just had to reschedule my patients for the rest of the day. We just do what we have to do and share the load and work as a team. So I find that really wonderful. And then it's the continuity of care and the relationships that you build with your patients and seeing good outcomes for them over time. And one that came to mind for me was a lady coming off long-term opiates that we've just been spending months and months counselling her on, and finally she, something clicked for her and she was able to come off them, and she feels amazing and is wanting to be a poster child for coming off opiates for other people in the community. So wonderful stories like that.
No, that's great, Mel. And, it's just so lovely to hear your story and what keeps you there. It's, it's what keeps us all there. And I think it's that real connection with community that is one of the key things that helps drive us and get out of bed every morning and do what we do. So thank you for that insight. Before we go to the other panel members to hear their amazing stories and their rewarding parts of their work, I might just quickly cut to a question that's come up on the panel from James. James is saying he's not even a medical student yet, which is fine, and we welcome you here, James, and thanks for getting online and being a part of this. So, and we absolutely want to encourage you to pursue a career in rural medical practice or any other healthcare practice that you might find yourself in. But it's not a silly question at all that you've asked about the opportunities for participating in research as a rural generalist. Many of my colleagues and I can speak for myself, have been involved in clinical research in rural practices. Our practice has just got a journal article published in the Australian Journal of Rural Health on the epidemiology of melanoma in rural practice, and it's a multi-centre retrospective analysis of the incidence of melanoma, and there were some really interesting findings in that research. So certainly there's opportunities for research. We encourage research. In fact, I think Ewan would agree with me, we certainly need more research. And one of the ways that we can dispel the myths about issues around the safety of rural practice or the efficacy of what we do is to build up that evidence to support the practice. And as I said, there is strong evidence that supports what we do. And I think, but certainly there's a need for more local Australian research, both clinically and epidemiologically. So not a silly question, James. Thanks for joining us, and hopefully that's answered your question. And we're just about to wrap up, but I'm going to go to Laura now to give us her rewarding story.
At the end of the day, it's interesting. And so I think it's a real privilege to be able to help them through what can be some really tricky times in their life. And I think working as a rural GP registrar, you get the opportunities often to see them come out the other side of those times as well. The other great thing about living in and working in the country is I feel like I actually get to see daylight. The only traffic I get on my road to work is maybe passing one car and some deer. And the air's better, it's cleaner. You're just out in the community, and I love it.
That's great, Laura. Excellent to hear. Ben, can you give us your final tips on or final insights into the rewarding parts of your rural practice?
Yeah, John, I'll just touch on a bit of an answer to James's question as well. Research doesn't have to be big and publicated either. It can be small things that are going to influence the way you work and your community. So 2 examples for me is when I was in Queenstown, actually looking into all the people that qualified for osteoporosis screening and management, something that's so underdone and sometimes forgotten about in primary care, but has quite disastrous outcomes, especially when you're 200 kilometres away from an orthopaedic centre. And that coincided with the DEXA screening bus coming down. So small internal audits as well that can inform your own practice. I guess for me, overall, the tips or what I enjoy is building relationships with patients. And the one that sticks in my mind and is the one that I always come back to is why I want to do and pursue what I want to do is an elderly fella that fell off his ladder and came into the small emergency department. He needed treatment, but he needed further scans. He needed to be seen somewhere else. But when he came back, he came to see me in the general practice for a follow-up for some pain management. And then a week later, he came back and he said, "Oh, I haven't, seen anyone about my blood pressure or my cholesterol for a little while, so thought I might come back to you and talk to you about that as well." So it's, moments in time where you meet a patient and then you build an ongoing relationship, and you can take your acute medicine and you can turn it into preventative health as well, which we know has such a big impact on people's health, and maybe more so than the hospital work that we do. So I think that's what I have down.
No, that's fantastic, mate. Thanks for that, Ben. And quickly, before I cut to Ewan's final word on all things amazing about rural practice, I'm going to quickly touch on Nicola Murphy's question. And she actually put this to you, Mel, around imposter syndrome and any insights you've got to overcoming or coping with that.
Thanks, John, and thank you, Nicola, for your question. Look, I think I am probably a person who is always going to feel a little bit of that imposter syndrome from time to time. And I feel like part of it is because we spread ourselves through various different aspects of rural practice. And, you know, we're not ever going to be wholly knowledgeable in everything. Like none of us can possibly know everything. I guess what I do try to do to combat it and cope with it is to make sure that I do everything that I can to keep my skills up to date and keep my knowledge up to date, make sure I read journal articles when I get the time. I do a little bit of exam question writing and marking with the RACGP, which helps, I guess, to keep me up to date with, you know, new guidelines, evidence-based, things like that. And I just do lots and lots of rural emergency skills program training courses. Pretty much just search and find all the courses that I can to make me feel more confident in these things. And of course, doing on call and doing the work and I guess just backing yourself. So trying to use some techniques that I use in mental health consults for myself. So being self-compassionate, clarifying my values, using some mindfulness techniques, and in a way faking it until you make it. So just, you know, putting on a brave face and actually doing it and backing yourself. You know, I think we've got these skills, like you said, John. There's evidence that that rural generalism works and is safe and is effective, and we need to back ourselves. So I need to do the same.
Great insights, Mel. And look, I don't think imposter syndrome is isolated to rural practice or generalist practice. There are many high-profile, influential city doctors and other specialists that feel the pressure of this as well. So I think, you know, as Mel said, the things that you can do are around staying current. Teaching is one of the best forms of learning, but I highly commend mindfulness, meditation, wellness, exercise. All of those things that we know are important to maintain our wellness generally is a huge part of that, and backing yourself, as Mel said. So that's fantastic. I'll give Ewan the last word on why he thinks rural practice is amazing, and then we'll wrap up.
Thanks very much, John. I'm just going to say it's amazing where rural practice can take you. It's amazing how much Australia is leading the way in the rediscovery of generalist medicine and of generalist family medicine, particularly in a rural context. Australia has assisted Japan in discovering a rural generalist model of care for its some 400 islands. I gave a presentation at a GP conference in Scandinavia a month ago, and the interest in rural practice and the challenges of getting doctors into rural practice is just as much an issue on the other side of the world as it is here. I've had Nepalese doctors ask me to talk about how a GP could still do emergency medicine in Nepal. So look, Australian rural medicine leads the way in the scope of practice, in the discipline itself, in the way we deliver quality care, that the rest of the world simply look at us and want to learn from us about what we're doing. So I love my job. I have a very busy job. But what I see before me is tremendous opportunities to teach not only students coming through and registrars, but to also teach the rest of the world what a great thing it is to be a country doctor. So thanks, John.
Mate, I absolutely back up and concur with everything you've just said then. Thank you, everybody, for joining us this evening. Remember, all the participants will go in the draw for the monthly Destination Rural Prize, and also for the grand prize to be drawn at the end of September for one lucky winner to receive travel accommodation and registration to attend Rural Medicine Australia on the Gold Coast from October 23rd to 26th, 2019. Remember, a recording of this webinar will be available for you. Don't forget to follow the conversation afterwards on the Destination Rural hashtag. And yeah, we're having lots of conversations online on Twitter about rural practice this week through the Croaky We Public Health Twitter handle. So continue the conversation between yourselves and with us online. Thank you again for being such a great audience, and we'll see you all next time. Have a good night.